Welcome to ASFA's last webinar of the dedicated webinar series honoring APHERESIS Awareness Day 2024. APHERESIS Awareness Day was celebrated on September 17th. The purpose of this day is to raise awareness of apheresis medicine and pay tribute to the many donors, patients, and apheresis practitioners that have dedicated their lives to saving others by using evidence-based practice to advance apheresis medicine. Today's webinar is entitled Hematopoietic Stem Cell Mobilization in Multiple Myeloma, presented by Jessica Peña. This webinar is hosted by BioLine. BioLine is pursuing life-changing therapies designed to deliver meaningful therapeutic benefits to patients with certain cancers and rare diseases. My name is Ashley, and I will be your webinar moderator today. Before we get started, I'd like to briefly go over the format for this presentation. There will be a 45-minute presentation segment and a 15-minute Q&A session. Please note that today's webinar is being recorded. You may post written questions at any time using the chat box beside the slides. All questions will be addressed during the subsequent Q&A session. I would now like to introduce our presenter. Jessica Peña is a lead stem cell transplant registered nurse coordinator with over 19 years of experience at MD Anderson Cancer Center. During her tenure, she has primarily concentrated on stem cell transplant and cellular therapy. Jessica, I will now hand it over to you.
Thank you so much, Ashley. Welcome, everybody. Thank you, BioLine, for hosting today. Again, we are talking about hematopoietic stem cell mobilization with APHERESIS or motixafortide in multiple myeloma. Ashley did a wonderful introduction. Again, I'm Jessica Peña. I've worked in stem cell transplant and cellular therapy for 19 years. BioLine is hosting this presentation today, and we are going to focus on APHERESIS or motixafortide. So let's get into hematopoietic stem cell mobilization in patients with multiple myeloma. Multiple myeloma is one of the most common indications for autologous stem cell transplants, or ASCTs. 35,000 people annually are diagnosed with multiple myeloma. Half of these people are eligible for ASCTs. Of these about half, 7,000 to 8,000, undergo ASCT annually. In 2020, multiple myeloma accounted for 59% of stem cell transplants performed that year alone. ASCT has been shown to prolong survival rate in patients with multiple myeloma, but the success of ASCT depends on adequate mobilization and collection of stem cells. When combined with therapeutic advancements, ASCT has extended multiple myeloma from less than 4 years to up to 10 years, as you can see here. An increasing number of patients with multiple myeloma are considered eligible candidates for ASCT, but some of these patients may experience mobilization challenges due to several factors, ranging from induction therapies to patient-specific risk factors. Some of those risk factors can include advanced age, prior mobilization failure, previous treatment with immunomodulating analog, platinum-containing regimens, alkylating agents, or purine analog, previous radiation therapy, or a baseline low CD34 cell count prior to apheresis. The proportion of older patients receiving ASCT has increased over the past decade. In 2011, it was 26% and increased up to 38% in 2021. Standard induction regimens in multiple myeloma can further impair mobilization, leading to fewer cells mobilized and additional days of apheresis required. Quadruple therapy regimens that include daratumumab are being recommended as first-line therapy for transplant-eligible patients with multiple myeloma. As age and use of these newer induction therapy regimens increase, most patients will require a CXCR4 antagonist mobilization, either upfront or as a rescue for ASCT. Like I said, many patients require multiple apheresis sessions to collect sufficient stem cells and may never progress to transplant. In a recent study in patients receiving cyclophosphamide plus filgrastim, commonly known as granular colony stimulating factor, or GCSF, or just filgrastim alone, in which successful collection was based on achieving a target of greater than 4 million CD34 positive cells, 5 to 6.3% of patients failed to successfully mobilize sufficient stem cells. In other studies, 50 to 75% of patients required more than one apheresis session to collect a target number of cells. Insufficient mobilization can lead to an increased burden on patients, from failure to mobilize enough CD34 positive cells or ASCTs performed with suboptimal apheresis products. Most patients will require a CXCR4 antagonist mobilization either upfront or as a rescue for ASCT, especially as these newer induction therapy regimens become more common and the average age of patients increases. The International Myeloma Working Group and the American Society for Transplant and Cellular Therapy both recommend a minimum target of 2 million CD34 positive cells for stem cell collection. While stem cell mobilization yields are grounded in the ASCT guidelines, stem cell collection goals in practice are more dependent on individual transplant centers. Centers may have various center-specific goals and algorithms to guide mobilization strategies for sufficient collection. Additionally, research has shown that processing, cryopreserving, and thawing of CD34 positive cells can significantly reduce the overall viability of collected cells. Again, upfront mobilization strategies may help patients meet the goals and then subsequently proceed to ASCT. APHERESIS, or motixafortide, is one of the first FDA CXCR4 stem cell mobilizers in multiple myeloma in nearly 15 years. We're going to talk more about APHERESIS now. This is Greg. Greg is our patient discussion today. He is a newly diagnosed multiple myeloma patient. He's 68 years old. He weighs 82 kilograms and has an ECOG status of 1. Greg's clinical history includes 4 cycles of an induction therapy, including carfilzomib, lenalidomide, and dexamethasone. He has achieved a very good partial remission, and his last induction cycle was 2 weeks ago. After weighing several various factors and several things along with Greg, his functional status and his age, his oncologist recommends him for ASCT and deems him eligible for ASCT. In addition to his health and upcoming procedure concerns, Greg and his caregiver are concerned about transportation costs, time, and the distance needed to travel to an apheresis center. We're going to come back to Greg and look at his collection journey and ASCT journey a little bit later in this presentation. APHERESIS is indicated in combination with filgrastim, or also known as granulocyte colony stimulating factor, or better known as GCSF, to mobilize hematopoietic stem cells to the peripheral blood for collection and subsequent autologous stem cell transplant in patients with multiple myeloma. APHERESIS is contraindicated in patients with a history of serious hypersensitivity reactions to motixafortide. How does APHERESIS work? This is the key feature. It is a CXCR4 antagonist. What happens in the stem cells or in the bone marrow is CXCR4 receptors play an important role in retaining the hematopoietic stem cells inside the bone marrow. The CXCL12 binds to the CXCR4 receptors, therefore keeping the stem cells in the bone marrow. The CXCR4 antagonists prevent the CXCL12 binding to this receptor. APHERESIS is the only peptidic CXCR4 antagonist that binds on a high affinity to the CXCR4 receptors on 6 point of contacts, and it occupies these receptors for greater than 72 hours. Therefore, by blocking the CXCL12 binding, the hematopoietic stem cells are able to move in the bloodstream, effectively increasing the peripheral CD34 cell counts. Again, the key features of APHERESIS here is the high affinity and the long receptor occupancy of greater than 72 hours allows for 1 dose of APHERESIS every other day as needed. Over a 24-hour period, peripheral CD34 cell counts with APHERESIS plus daily filgrastim were nearly 4.5-fold higher compared with the placebo plus daily filgrastim. As you can see here, the median fold increase in peripheral CD34 positive cells was 6.7 in the APHERESIS treatment arm versus 1.5 in the placebo arm. The Genesis trial was done with APHERESIS. The Genesis trial was a 2-part trial. Part 1 was a single open label investigation to confirm the dosage. Part 2, as you can see in this diagram here, was a phase 3 randomized double-blind, placebo-controlled, multi-center study to evaluate APHERESIS in combination with daily filgrastim on mobilization for ASCT in 122 patients with multiple myeloma. There were 18 sites in North America and Europe, and the patients were stratified by remission status, complete or partial response, and by baseline platelet count. As you can see in this figure here, in the mornings on day 1 through 5, and additionally days 6 through 8 if needed, all patients received filgrastim 10 to 15 micrograms via subcutaneous injection. In the evening on day 4 and day 6 if needed, patients received either APHERESIS 1.25 milligrams per kilogram or the placebo. All patients began apheresis on day 5. All patients had a stem cell collection goal of greater than 6 million CD34 positive cells. If necessary, based on the collections, the apheresis continued on day 6 through 8. Again, filgrastim was given every day of collection, and then motixafortide was given on evening of day 4. Before we review the baseline characteristics of the Genesis patient population, I do want to note here that when the Genesis clinical trial was designed in 2018, the standard of care induction regimen in patients with multiple myeloma who were eligible for ASCT was a three-drug regimen containing an immunomodulating agent, a protein inhibitor, and a corticosteroid. As you can see on the graph or on the chart over here, baseline characteristics across the APHERESIS and the placebo arm were very similar. Demographics were documented on both. The median age of patients was 63%, but I want to bring your attention down to the bottom of the page where it talks about lenalidomide. Approximately 70% of patients were previously treated with lenalidomide in both the APHERESIS and the placebo arm. We do know that previous treatment with lenalidomide can negatively affect stem cell count yield and increase mobilization failure rates when mobilizing with filgrastim alone. There were several endpoints to the Genesis trial. The primary endpoint was the proportion of patients who achieved a stem cell collection goal of greater than 6 million CD34 positive cells in up to 2 apheresis sessions after administration of daily filgrastim and a single dose of APHERESIS or the placebo. The secondary endpoints were kind of a high and low. That was the proportion of patients that collected greater than 2 million CD34 positive cells in one apheresis session with APHERESIS or the placebo, and then also looked at the proportion of patients who collected greater than 6 million CD34 positive cells in one apheresis session following the administration of filgrastim and APHERESIS or the placebo. The Genesis trial also evaluated time to neutrophil and platelet engraftment and graft durability during the transplant. To note, both central and laboratory assessments were used in this trial. Central laboratory assessments were used for the principal statistical analysis of efficacy, and local laboratory results were used for clinical treatment decisions. Central laboratory assessments used the validated single platform method, provided standardization across all the countries and all the different sites. The central sampling assessment was performed 24 to several days after the apheresis collection had taken place. Local laboratory results were readily available and guided clinical decision-making on further apheresis sessions. Patient CD34 cell count was measured on the day of the apheresis by the local laboratory. If the count reached or exceeded that 6 million CD34 positive cells, no apheresis sessions were performed. So what were the results? Again, we're looking here at central laboratory data, and after only one dose of APHERESIS plus filgrastim, the majority of patients successfully collected greater than 6 million CD34 positive stem cells. Looking at the primary endpoint, 67.5% of patients mobilized 6 million CD34 positive cells following one dose of APHERESIS plus filgrastim in up to 2 apheresis sessions, compared with 9.5% of patients who received the placebo plus filgrastim. That yields an adjusted difference of 56.8%. In the secondary mobilization endpoints, again, those kind of high and lows, 63.8% of patients achieved the 6 million CD34 positive cells following one dose of APHERESIS plus filgrastim in one apheresis session, compared with only 2.4% of patients who received the placebo plus filgrastim, yielding an adjusted difference of 60.5%. In the lower side, the percentage of patients that collected greater than 2 million CD34 positive cells in one dose of APHERESIS plus filgrastim in one apheresis session was 87.5%, compared with 38.1% of patients who received the placebo plus filgrastim, again yielding a difference of 48.3%. Based on statistically significant evidence favoring APHERESIS, as you can see on this diagram, the Independent Data Monitoring Committee recommended patient enrollment be ceased without recruiting all 177 patients originally planned. Here right now, we're looking at the local laboratory assessments. These were conducted at the local centers. They collaborate very well with the central data as well. 92.5% of patients treated with the APHERESIS plus daily filgrastim achieved greater than 6 million CD34 positive cells in up to 2 apheresis sessions, compared with the placebo plus daily filgrastim at 21.4%. Those secondary endpoints, the 86.3% of patients treated with the APHERESIS plus daily filgrastim achieved that greater than 6 million CD34 positive in one apheresis session, compared with 9.5% of patients who received the placebo plus daily filgrastim. Additionally, 96.3% of patients treated with the APHERESIS plus daily filgrastim achieved that greater than 2 million CD34 positive cells in one apheresis session, compared with 61.9% of patients who received placebo plus daily filgrastim. Local laboratory assessments were used for sensitivity analysis. The assessments are descriptive, not statistically powered, and not pre-specified. The information should be cautiously interpreted. Nearly 5 times more stem cells collected in one apheresis session in the APHERESIS treatment arm compared with the placebo arm. Central laboratory data showed that after one dose of APHERESIS plus daily filgrastim, on average, patients achieved 8.5 million CD34 positive cells, compared with the placebo plus filgrastim at 1.5 million CD34 positive cells. The local laboratory assessments show very similar results. After one dose of APHERESIS plus daily filgrastim, on average, patients collected 10.8 CD34 positive cells, compared with the placebo plus filgrastim at 2.1 CD34 positive cells. Median collection of CD34 positive cells collected are presented as median values. You can see a minimum and a range here, but without comparative statistics, as these were not pre-specified analysis, the information should be cautiously interpreted. What are the big results here? After one dose of APHERESIS and filgrastim, 56.8% more patients compared with the placebo plus filgrastim achieved CD34 positive cells of greater than 6 million in up to 2 apheresis sessions. Multiple factors can influence time to neutrophil and platelet engraftment and graft durability. In the Genesis, the outcomes for these endpoints evaluating these key points were similar across both the treatment with APHERESIS and the placebo arm. The safety of APHERESIS was evaluated in the Genesis trial based on 92 patients with multiple myeloma who received one dose of APHERESIS and filgrastim and patients who received the placebo plus filgrastim. The most common adverse reactions occurring in the Genesis trial were injection site reactions. 73% of patients reported this. These injection site reactions included pain, erythema, and pruritus. Additionally, the other common side effects were systemic pruritus, flushing, and back pain. Serious adverse reactions occurred in 5.4% of patients receiving APHERESIS plus daily filgrastim. Serious adverse reactions included vomiting, injection site reaction, hypersensitivity reaction, injection site cellulitis, hypokalemia, and hypoxia. Across the entire developmental program, anaphylactic shock occurred in 0.7% of patients treated with the APHERESIS plus filgrastim. Acute injection site and systemic reactions should be anticipated based on this clinical trial experience. You saw the chart in the previous slide. So it is key to pre-medicate before each dose of APHERESIS to reduce the risk of these hypersensitivity reactions and the injection site reactions. We will talk about that a little bit later. It is key to note that the incidence of diarrhea in part 2 of the GENESIS study was similar in both arms, 2.5% in the APHERESIS treatment arm and 2.4% in the placebo treatment arm. Interesting, bone pain occurred less frequently in the APHERESIS treatment arm at 17.5% than in the placebo arm at 31%. So let's dig a little bit deeper into dosing and administration of APHERESIS. You need to first determine the dose of APHERESIS based on the patient's actual body weight. Again, the dose that is recommended is 1.25 milligrams per kilogram. You will always administer filgrastim 10 micrograms per kilogram sub-Q once daily for 4 days prior to the first dose of the APHERESIS in the evening, prior to the first dose of APHERESIS. You will administer the first dose of APHERESIS in the evening on the 4th day, about 10 to 14 hours prior to the start of apheresis. APHERESIS is given in a single dose and it must be reconstituted with half normal saline. The key things about administering APHERESIS is it's going to be a slow subcutaneous injection, over 2 minutes per syringe. Each syringe or injection volume should not exceed 2 mLs. So if your patient dosing does go over the 2 ml, you need to divide the doses into 2 syringes and allow 2 different injection sites. No additional dose of APHERESIS is needed on that second day of collection. If another dose, a third day of collection is needed, then you can give APHERESIS on the evening of day 6, 10 to 14 hours prior to the apheresis. You're going to continue the filgrastim every single day of 4 days prior to the first APHERESIS dose and through the collection days. Based on population PK analysis in patients with mildly to moderately decreased renal function, the pharmacokinetic profile of motixafortide was not significantly affected. While the effect of severe renal impairment on clearance of motixafortide has not been evaluated, there isn't a significant effect anticipated. I mentioned pre-medication, so let's dig a little bit deeper into that. Pre-medications are required before each dose of APHERESIS to reduce the risk of the hypersensitivity and injection site reactions. The following medications should be administered 30 minutes to 1 hour before injecting APHERESIS. Benadryl, either IV or orally, or another H1 antihistamine, an H2 blocker, such as famotidine, and a leukotriene inhibitor, such as montelukast. The addition of an analgesic medication, such as acetaminophen, is also recommended. Researchers at Washington University in St. Louis conducted a post-hoc subgroup analysis of the effects of the pre-medication regimen in 46 of the 122 patients in the GENESIS trial. Due to the timing of a protocol amendment, 14 patients in total in this post-hoc subgroup analysis received the 4-drug combination pre-medication regimen, as I just discussed, 10 of whom were in the APHERESIS treatment arm. In this post-hoc subgroup analysis, decreases in systemic and injection site reactions were observed in patients taking the 4-drug combination pre-medication regimen versus those patients who received a single pre-medication, an H1 blocker, up to 30 days post-APHERESIS administration. As you can see here in this graph, hypersensitivity reactions was 91% with a single H1 blocker and 20% with the combination regimen. Injection site reactions were reported at 96% with a single H1 blocker versus 80% with the combination regimen. The assessment in this post-hoc subgroup analysis are descriptive, not statistically powered, and not pre-specified, and it was a very small group of patients, so they should be cautiously interpreted, but it does show that the pre-medications are very effective in counteracting that hypersensitivity reaction. APHERESIS should only be administered in a setting where personnel and therapies are immediately available for treatment of anaphylaxis and other systemic reactions. Patients additionally should be monitored for signs and symptoms of hypersensitivity reactions for 1 hour following the administration of APHERESIS. Now we're going to welcome Greg back in. So remember, Greg was recommended to proceed to ASCT by his local oncologist. And after some discussion, Greg decided to proceed with mobilization, and his oncologist just chose to use APHERESIS. Prior to the APHERESIS administration, filgrastim was given every morning for the previous 4 days. He was then pre-medicated with the 4-drug regimen of Benadryl, famotidine, montelukast, and acetaminophen 30 minutes before his first APHERESIS dose. His APHERESIS dose was given, it was 1.25 milligrams per kilogram. He was again 82 kilograms, so his dosage was 2.8 mLs. The 2.8 mLs was divided into 2 syringes due to the max delivery of each injection to 2 mLs. Each syringe was administered to Greg's abdomen, again, separate injection sites in the evening on day 4 of the filgrastim administration. Greg was monitored for hypersensitivity reactions during and for 1 hour following the injection. Greg was able to mobilize greater than 6 million CD34 positive cells in 1 apheresis day, and then Greg did proceed to autologous stem cell transplants. All patients receiving APHERESIS should be advised of the following. There is a possibility of anaphylactic and hypersensitivity reactions such as pruritus, flushing, urticaria, rash, redness, vomiting, nausea, and chills during and after the APHERESIS injection. Immediately report such signs and symptoms to the healthcare professionals. Most of them will be monitored for 1 hour after the injection. APHERESIS may also cause injection site reactions such as pain, redness, swelling, and rash. Additionally, all women of reproductive potential receiving APHERESIS should be advised of the following. The need for the use of effective contraceptive methods during the APHERESIS treatment and for 8 days after the administration of APHERESIS. The potential risk to a fetus, there is potential risk to fetuses, and they need to contact their healthcare provider if they become pregnant or if pregnancy is suspected during the treatment with APHERESIS. Additionally, we need to advise women that breastfeeding is not recommended during treatment with the APHERESIS and for 8 days following the last dose. BioLine is here to help. They have a Connect patient support system. They're committed to helping patients who have been prescribed APHERESIS with access and appropriate financial support. Some of the programs that they have are access and reimbursement, which includes navigating through the insurance process, including benefit investigation, claims assistance, prior authorizations, and appeals. Financial assistance for those patients eligible who are uninsured or lack coverage and qualify for assistance with their out-of-pocket drug costs. And then resource support, identifying information and support services for patients and their caregivers. You can see the Connect patient specialists are available Monday through Friday at that number listed. We've discussed a lot of the important safety information throughout the presentation, but I want to highlight a few things that we have not covered yet. Patients receiving negative chronotropic drugs, such as beta blockers, may be at more risk for hypotension in the event of a hypersensitivity reaction with these drugs. So when appropriate, these should be replaced with non-chronotropic drugs. Severe injection site reactions occurred in 9% of patients. Using the analgesic medication acetaminophen prior to each dose of the APHERESIS and post-treatment, local treatments post-dose as needed. For the purposes of hematopoietic stem cell mobilization, APHERESIS may cause mobilizations of leukemic cells and subsequent contamination of the apheresis product. Therefore, APHERESIS is not intended for hematopoietic stem cell mobilization and harvest in patients with leukemia. Administering APHERESIS in conjunction with filgrastim increases circulating leukocytes as well as hematopoietic stem cell populations. You need to monitor white blood cell counts during the APHERESIS use. When APHERESIS is used in combination with filgrastim for hematopoietic stem cell mobilization, tumor cells may be released from the marrow and subsequently collected in the leukapheresis product. The effective potential reinfusion of the tumor cells has not been well studied. Based on its mechanism of action, APHERESIS can cause fetal harm. We already talked about this, but you need to advise pregnant women of the potential risk to the fetus, verify pregnancy status before treatment of APHERESIS, and advise them on effective contraceptive during the treatment and for 8 days following the final dose. There is no data on the presence of motixafortide in human milk, as we discussed previously, but we want to advise females that breastfeeding is not recommended during the treatment with APHEXDA or for 8 days after the dosage. The safety and effectiveness of APHEXDA has not been established in pediatric patients. So, exciting key takeaways. As age and the use of 3 and 4 drug induction therapy regimens increase, most patients require multiple apheresis sessions, and some may never progress to transplant. Overall, a majority of patients who received APHEXDA plus daily filgrastim collected target cell counts following 1 dose of APHEXDA and in 1 apheresis session, compared with patients who received placebo plus daily filgrastim. The long receptor occupancy of greater than 72 hours allows for a prolonged PD effect. In healthy subjects, CD34 positive cells in peripheral blood remained high 24 hours following 1 dose of APHEXDA plus daily filgrastim. That allows you to have 2 apheresis sessions for every 1 dosing of APHEXDA. APHEXDA has a demonstrated safety profile. The most common adverse reactions were injection site reactions. These included pain, erythema, and pruritus, and then systemic pruritus, flushing, and back pain. We want to pre-medicate to reduce the risk of hypersensitivity and injection site reactions, and monitor our patients closely for 1 hour after the administration of APHEXDA. I thank you guys so much for listening to the presentation today. Now we're going to open up the Q&A.
Thank you so much, Jessica. So this concludes the presentation segment of the webinar. We will now begin our Q&A session by addressing the written questions submitted through the chat box. So if you do have any questions, please type in your questions in the chat box. I will be sending a written announcement here, so that's where you can submit any of your questions. And I would now like to welcome Tom Pickett, U.S. Marketing of BioLine, to moderate this Q&A session.
Well, great job, Jessica. And we will give folks a couple more minutes. I don't see any questions coming in yet. So give me a couple minutes. We'll give folks some time to digest that. And that was a really fantastic presentation by Jessica. So thank you.
Thank you, Tom, very much.
We have one question that came in, Jessica. So the question is, and let me send it over to you as well. So are you still administering filgrastim the day of the apheresis collections?
That is correct. So the daily filgrastim is given for 4 days prior to the first dose of APHEXDA, and daily filgrastim continues every day of collection.
One of the next question from the chat, Jessica, is APHEXDA given daily?
APHEXDA is given on the evening of day 4 prior to the first collection on day 5. The 1 dose of APHEXDA covers 2 apheresis sessions, so it is not repeated on the evening of day 5. You can proceed to a second collection on day 6 if necessary, based on the CD34 cells collected. If additional therapies and apheresis is required, you will continue the daily filgrastim and give a second dose of APHEXDA on the evening of day 6, 12 to 14 hours prior to that third apheresis collection.
All right, another question, Jessica, is, do you do CD34 peripheral counts to determine if needed? If needed to do an apheresis session.
In the Genesis trial, CD34 counts were not monitored, were not reported. We based it off of the CD34 cells collected and the collection totals. Given the APHEXDA, how the APHEXDA works, and with daily filgrastim, you do want to monitor white blood cell counts as you are giving them, though, giving the dosages and collecting. But there are not dose levels to give or not to give.
All right, another question for you, Jessica, is what is the minimum age that APHEXDA is approved for?
APHEXDA, the Genesis trial was done in the adult population, so 18 years or older. It was not tested in pediatric patients at this time. Great questions. Thank you, everyone.
And let's give folks a few more minutes if they want to jump in and add additional questions. All right, let's give it another minute or two for any other questions. Then I think we can call it.
Okay. So it looks like we have reached the end of the webinar. If you have sent in your questions, we did receive them, but if they weren't addressed, we will send you an email privately so you can reach out to BioLine to get your questions answered. And I thank everyone for joining us today. Again, you'll receive a post-webinar email with more information in a few days. You can reach out to BioLine to get your questions answered if they weren't addressed today. Thank you so much to Jessica for speaking with us today and for BioLine for hosting today's webinar, and for Tom, of course, for moderating today's Q&A session. Thank you so much again for joining. Oh, go ahead, Tom.
And one thing I wanted to add, so any questions that weren't answered, I'll be following up with those folks directly. We can get those answered. We can get those questions answered for you. So I'll be compiling a list of those and reaching out to those folks directly.
Perfect. Thank you so much, Tom. Again, thank you so much for joining us. We'll send you an email after this webinar in a few days. Have a great day, everyone.